So I'm an NHS doctor, and the kind of drugs that we use in the NHS are, to some extent, quite a lot of them are generics, and the generic drugs are often associated with the same degree of variability that you'll see within new therapeutic entities. And I'll talk mostly about generic drugs and how trying to tackle some of the issues with personalised medicine in relation to generic drugs. So you've seen something like this before, but a slightly different way of showing this. We, at the moment, deal with diseases in terms of classifications from the last couple of centuries, and it's really very much a phenotypic definition, and John Bell clearly showed why that is a deficiency in terms of what we do in treating patients. As we learn more about the disease, the molecular definition, that will allow us to be able to stratify diseases, and the stratification may be related to genomics, but also other types of stratification. But even when we get into strata of disease or subphenotypes of disease, and when we're using specific drugs within that particular substratum of the disease, there will still be some variability of the drug in terms of the way it's handled by the body, as well as the way it interacts with the target in the cell in the body. And that is where you need to be able to utilize pharmacogenomics. And finally, to really practice personalized medicine, we need to take into account what patients do. Patients eat different things, they drink different amounts, they smoke, they may be on they may have comorbidities, but also on other drugs as well. And we need to be able to look at all of that to really practice personalized medicine. The problem, obviously, electronic health records may be important here and crucial, but the data quality in electronic health records will have to be improved to be able to really capture the environmental effects. A typical example is that when I go around, do ward rounds, the typical way that junior doctors describe a patient's alcohol intake is social. And social to junior doctor may mean completely different to somebody who's a patient, I can tell you that. So, drugs can be developed on the basis of the genetic variants that you can see in that particular disease-causing genes, but genes also affect the way the drugs are handled. So I'll give you two examples of the first. And there are people in this audience who are much more expert in this area than I am, but a typical example is using sequencing technologies, identifying driver mutations, and then developing a targeted therapy. A typical example here is with metastatic malignant melanoma, with fantastic responses within a couple of weeks of having a drug which is targeted to a particular mutation in the BRAF gene here. Unfortunately, we all know with targeted therapies, in majority of cases, that you do get recurrence, and the next challenge here is how do you actually use multiple different drugs in the same pathway to be able to prevent that recurrence from occurring. The second example of how you can utilize a gene defect to be able to develop drug is this example from Vertex Pharmaceuticals, where they've targeted this particular mutation in the cystic fibrosis gene, which only affects 4% of individuals, this particular gene, and able to identify a drug which is able to make that protein on the membrane function better with this drug, ivacaftor. In terms of the screening efforts they undertook was fantastic, and a very superb innovation which shows that you can actually try to develop pharmaceuticals based on the genetic defects that you see in different diseases. And although this was licensed for one particular mutation which affects 4% of individuals, the FDA expanded the indication on these other mutations which also have been shown in vitro particularly to be able to respond to the same drug. The next challenge is to be able to target the 75% of patients who have the delta 508 mutation in cystic fibrosis, and there is a combination of drugs which is lumacaftor and ivacaftor, which doesn't have the same response, which is 10% increase in FEV1 as seen in this particular mutation, but nevertheless, if you've got a misfolded protein, to be able to unfold it and then get it to the membrane is a tough thing to do, but nevertheless lumacaftor says you can potentially do it, but needs further work in that area. Then let me just go on to the second example of how your genes can affect drugs. So Paracelsus said that the drug is the poison. It can be therapeutic or a poison, and the dose is what makes it either therapeutic or a poison. But what he didn't know was that when we give a dose to different individuals, so if I gave you the same dose of a drug, there'll be massive variability in the levels of the drug in your bloodstream and therefore in your tissues where the drug may work. So the dose does not necessarily equate to exposure. And what we don't do at the moment is take into account exposure. And exposure is a major influence of how well a drug works or how well a drug causes toxicity. And typical example, now this is starting to come through. An example of this is with this drug, eliglusat, which is being used, which was licensed in Gaucher's disease by the FDA. And this drug is actually metabolized by a very polymorphic enzyme, which is absent in 8% of the Northern European population. And the label for this particular drug now says that you've got to be able to individualize a dose based on the genotype of the cytochrome P450-26. So if you're a poor metabolizer, you get a lower dose than if you're an extensive metabolizer. And there are going to be examples of these kind of drugs coming through where we individualize dose on the basis of exposure. And that is personalized medicine for that particular individual. Then another example, which is a generic drug, which is widely used in most developed countries and still the most widely used oral anticoagulant, despite the new oral anticoagulants, is warfarin, which is used in 1% of the UK population, used for venous thromboembolism, atrial fibrillation, prevention of strokes, and so on. And warfarin's been around for 60 years, but despite that history and the experience that we have with warfarin, it still causes major problems. It is in the top 3 of drugs which cause admission to hospital because of bleeding episodes, such as in this 82-year-old patient. And the major problem with warfarin is how do you define what the dose is for that particular patient. Some patients require 0.5 milligram a day, some patients require 20 milligrams a day. And if you look at what factors affect your individual daily dose requirements for warfarin, there are many environmental factors, but also genetic factors. And the genetic factors relate to the mechanism by which warfarin acts. So warfarin is handled by an enzyme called cytochrome P450-2C9, which is variably expressed in the population. And also it acts on vitamin K epoxide reductase complex, inhibits the vitamin K cycle, and therefore prevents the formation of the vitamin K-dependent clotting factors. So work which has been undertaken in many parts of the world, including by ourselves, has been able to try to define what the variance is overall and what factors determine that particular variance in daily dose requirement. And here's a Manhattan plot on mean weekly dose from a UK cohort that we looked at. And you can see that the two hits on the Manhattan plot with p-values 10 to the minus 30, 10 to the minus 50, just with the 714 patients, were these two genes which interact with warfarin in the way it acts. But if you then also look at some of the environmental factors, so age accounting for 11% of your dose variation, as you get older, you need a lower dose of warfarin because your liver gets smaller. So this is something to look forward to as your liver gets smaller. As you get older, you are more interacting medication, and that also accounts for what will happen to your warfarin dose requirement as well. So based on this, you can see that the genetic factors are by far more important in determining your individual daily dose requirements of warfarin. So what we did was to say, well, actually, why don't we undertake a randomized controlled trial to be able to show the utility of this? And we did do that. This was sponsored by the EU Commission, and we worked with LGC, which is a company which is based in Teddington in the UK. They developed a point-of-care platform for us, which was able to measure, which was able to look at 3 alleles, 2 in cytochrome P450-2C9 and 1 in vitamin K epoxide reductase complex within 2 hours. So a patient comes in, they give us 1 ml of blood, you don't need DNA extraction, you put it into the platform and you get the result in 2 hours. You can then plug those results into an algorithm that we developed, which tells you what the dose should be individualized to that patient. So if you randomize to that genotype arm, you got that individualized dosage, and then we compared it to standard care in the UK, which was 10.55 on the first 3 days. And we then followed up the patients for 3 months to see how well they responded to the individualized dose compared to the standard dose that we use at the moment. And this was published in the New England Journal of Medicine at the end of 2013. And if you look at the control arm, what we get, 60% time in range for the first 3 months, which is a primary outcome measure, which is pretty good anyway, because most anticoagulant clinics will run about 50 to 55% anticoagulant control. Yet in the genotyped arm, we got a 7% improvement in the time in range. And I don't have time to show you all the individual data in terms of time to therapeutic range, etc., but all those parameters improved with the genotype-guided dosing. So we were criticized for the fact that this is a surrogate marker, INR, and we were only able to show an improvement in surrogate marker. However, 3 weeks ago in the Lancet, a study was published which looked at this particular trial, which was ENGAGE-AF-TIMI, which compared edoxaban, a neuroanticoagulant, to warfarin, and was able to show that on the warfarin arm, you could actually start looking at the genetics of the cytochrome P452C9 vitamin K epoxide reductase complex. And what these investigators did was to categorize the individuals, either those who are non-sensitive, those who are sensitive, or those who are highly sensitive. And what they're able to show was that the genetics actually increased your risk of bleeding within the first 90 days, same time interval that we followed patients up for. And the factors, the genetic factors, added value above those clinical factors which are already used in clinical practice to be able to identify those individuals who bleed. So that tells you that genetic factors are important. And what we're doing at the moment is working again with LGC to implement the genotype-guided dosing within, first of all, 3 primary care clinics, and then hopefully roll them out further into other primary care clinics. Again, we've also shown this is cost effective for the NHS to be able to do this. The data is not published yet, just about to go to a journal. Then the other area that is also important is on serious adverse drug reactions. This is things such as the serious cutaneous reactions, such as toxic epidermal necrolysis or drug-induced liver injury. And drug-induced liver injury is still a major problem for the pharmaceutical industry. 20% of drugs are still withdrawn because of drug-induced liver injury. And exposure is also important here. For example, with phenytoin, cytochrome P452C9 was only hit in terms of determining the risk to a serious cutaneous reaction such as this one. But more commonly, what we have found and other people have found is that the HLA system is particularly important in predisposing to these serious reactions which are immune-mediated. So abacavir is the poster child for this. There's an association found with 5701. But importantly, apart from the fact that it's now used as a predictive test, this has also told us something about the mechanism by which how drugs are presented to the immune system. Using crystallographic studies, people have been able to show that abacavir binds to the F pocket, and when it binds, it changes the peptide binding profile within the MHC cleft, and therefore changes the immune response that occurs and leads to the huge immune response. As I said, this is now implemented in clinical practice. Since 2006, every HIV clinic in the UK has been using this particular test. And the net effect of that has been dramatic. The incidence of hypersensitivity before the test was introduced was 7%. Now the incidence is less than 1%. So this is personalised medicine in practice in the NHS and in all other healthcare systems, most of the other healthcare systems in the world. There are many other new HLA findings been found. These are 3 that we've identified. 3 things to look at here, that these are different drugs therapeutically associated with different HLA alleles, but also done on genome-wide scale with small numbers. So 52 cases, 22 cases, 51 cases, where you're getting p-values lower than 10 to the -8. Now, the next step, obviously, is are they of enough predictive value or negative predictive value to be able to implement into clinical practice? So, in fact, since the beginning of the century, there have been 24 different associations at genome-wide significance, which have been identified associated with HLA alleles in terms of serious adverse drug reactions. So the question then, and the big problem that we have is, how do you implement something like that? At the moment, to get one HLA test done in the NHS will cost well over £100, one allele, and it will take at least 2 weeks to get the result back. Obviously varies different parts of the country, depending on whether you're close to a regional immunology laboratory and so on. And so one of the things that we're working on, again with an SME who has got some novel technology, is to develop a 24 allele biomarker panel, which will be available within 48 hours, and turnaround time is extremely important to the physician who wants to prescribe a drug. But it will also be less expensive than the individual HLA allele tests which are done in the NHS at the moment. And even if you are just going for one particular allele, the rest of the results will be available in your electronic case record to be able to use later on. Unfortunately, all of us get older, some of us will then get gout or something else, and you will need those kind of results in your electronic case records for the future. So, however, implementation of these kind of testing is not going to be easy. And here's a salutary lesson from Hong Kong. In Chinese individual patients, having an allele called HLA-B1502 massively increases your risk of getting carb-mazepine-induced Stevens-Johnson syndrome, toxic epidermonecrosis. And this has now been put into the label. It's mandatory to test that in the label for carbamazepine. And so the Hong Kong government saw the data and then produced a screening policy where they paid for the test in the Hong Kong healthcare system. And so what these guys did was to see what effect that test had on the incidence of SGSTEN. And I won't go through every bullet point there, but let me just summarize. Because there was a genetic test available for a particular drug and it was mandated by the government, what most doctors did was to actually use a different drug for the treatment of epilepsy to avoid the genetic test. And when they did that, those other drugs are also associated with SGSTEN. So overall, the incidence of SGSTEN did not decline. But when you did use the genetic test, it did decline. So you can see that what physicians will do is actually use the easiest pathway where you don't have to do testing. Because still, at the moment in healthcare, and when I talk to colleagues of mine, genetic testing is very much regarded as a disruptive technology. And so the implementation is always going to be difficult for us to be able to take into clinical practice. So just to leave you with this particular slide, and this is data from the European Medicines Agency. These are all the drugs which have got a mandated genetic testing before the prescription of a drug. That is in section 4.1 of the summary product characteristics. All of them are in cancer apart from 3. And the 3 are abacavir, which I already mentioned, ivacaftor, and the drug for Gaucher's disease that I mentioned before. And while personalized medicine is hugely important in cancer, and there are huge strides being made in that area, as can be seen by this table here, there is a bigger issue as well in some of the non-cancer areas in terms of identifying biomarkers and then taking personalized medicine into practice, not just genomics, but also the other omics technologies as well. And so just to finish off, to thank all the people who work with me, plus some of our funders, as well as the Serious Adverse Event Consortium that was mentioned in the previous talk. So thank you very much for your attention.